So good day everyone. Today I'm going to lecture about facial lacerations and a basic on wound suturing. I am Arik Paolo Delacruz. I am a professor at the Visayas State University College of Medicine. So for my references, most of the material I use in this lecture is from journal from the American Academy of Family Physicians entitled Laceration Repair, A Practical Approach. It was released 2017 and you can actually download this from their website www.afp.org. And I should say that this is a really good read, especially for those who are interested in suturing. Me myself, I found it really interesting and gives me a really good insights in suturing wounds, and I hope you also read this one. The next reference is of course from Schwartz, Principles of Surgery. It's our textbook in surgery. And I also got some pictures from the internet, and these pictures are only for educational purposes only, and I give credits to the owners. So what are the common ENT complaints in the ER? So these are the list of common ENT complaints in the ER, and this was compiled from various journals all over the world, and they found out that the most common among the ENT complaints is maxillofacial trauma. And maxillofacial trauma, there is some kind of an injury, especially injury to the face and the skin. So around 6 million patients present to the emergency department for laceration treatment each year. Lacerations to the face and scalp, 50% of them are being managed at the ER, and the most common causes of the lacerations to the face includes falls, sports, violence, motor vehicular accidents, animal attacks, recreational activities, and self-inflicted injuries. So in this lecture, I will discuss to you in 4 parts. First part, we will review a little about wounds and healing. We'll discuss a little about basic principles on wound healing. Part 2 is how we prepare the wound, things that we have to do before suturing. The third part is about suturing the wounds, and I will discuss here the basic suturing techniques. And part 4 is post-suture care, things that we have to do after we have sutured the wound. So this lecture is limited only to cutaneous suturing of the skin. And what I will teach here are very basic techniques and will only include discussion of the basic instruments and materials for cutaneous suturing linear wounds, making elliptical wounds, and I will not tackle so much on advanced techniques such as skin rearrangement or flaps, scar revision, cutaneous cancer surgery, and advanced wound repositioning techniques. So this will suffice, especially if you are getting started in suturing wounds. This will be adequate already. So part 1, wounds and healing. So let's talk about wound healing. So the first part of wound healing is actually hemostasis. Some books don't include this hemostasis part, but it is nice to know that in every wound there's some kind of hemostasis done by the body in order to stop the bleeding. The second phase of wound healing is the inflammatory phase. This is where the body will send out inflammatory cells to combat infection or to engulf foreign bodies and set out inflammatory cascade wherein wound healing will start. And the third phase is proliferative phase. It is the phase wherein the body's cells try to repair the wounds itself. In this phase also, the fibroblast will try to fill up the gap so that the wounds won't have gaps in them when they're healing. And the next phase is the remodeling phase. This is a phase wherein the body tries to make the wound go back to the pre-injury state. Here we will talk about wound healing sequence. So wound healing is a sequence. It means that wound healing goes through all the phases and it doesn't skip one phase. It has to go through all the phases before it fully heals. For example, inflammatory phase will have to be followed by the proliferative phase, then the remodeling or maturation phase. It cannot skip. For example, inflammation, it will go directly to maturation. It can't, because it is a sequence. However, phases can be delayed because of local or systemic factors. For example, the inflammatory phase, if there is still inflammation in the wound and it wasn't addressed, then the inflammatory phase will be prolonged. And thus, overall, the wound healing process is also prolonged. So, you cannot skip, but it can be delayed. Okay, it is like going through an immigration. When you go into a country, you will have to have stops. You have to go through all the stops. You cannot skip stops, but you can be delayed depending on your papers, etc. So these are the factors that delay wound healing. I got this from Swartz. And so systemic factors that affect wound healing are the following: age, nutrition, trauma, metabolic diseases, immunosuppression, connective tissue disorders, and smoking. Local factors include mechanical injury, infection, edema, ischemia or necrotic tissues, topical agents, ionizing radiation, low oxygen tension, and foreign bodies. So as doctors, we should optimize the wound healing so that healing would be as quick as possible by eliminating factors that can delay it. So that's why we should prepare the wound prior to suturing so that we could have the optimal wound healing for our patients. Clinical approaches to wound healing. So in wounds, there is usually a gap. Okay, a gap wherein one edge of the skin and another edge of the skin is separated from each other, and there is a gap in between. Okay, so a longer gap takes a longer time to heal. So what we do is we have to close the gap by the following approaches. First is via primary intention, wherein we have to suture the gap so that the gap will be closed. The second is the secondary intention, wherein we let the body fill the gap by itself. In this example, okay, the fibroblast will fill up the gap and it will take time, but it will close eventually. And this is what we call secondary intention. We do not do anything about it. The body will just take care of it. And the third is the tertiary intention, wherein we let the gap close until it reaches a point wherein the gaps are narrower than before. Then after that, we proceed with suturing. So primary intention and the tertiary intention needs some kind of suturing in them. So when do we use a primary, a secondary, and tertiary intention? Primary, if there is no infection in the gap, we can close it. Okay? And for a secondary intention, it is usually used whenever there is still an ongoing infection or inflammatory process in the wound, that if we suture it, we run the risk of trapping the infection inside, and thus it will defeat the purpose. It is also used wherein the gaps are really so wide that suturing will fail anyway. Or whenever the patient doesn't want to be sutured, then we opt for secondary intention. Tertiary intention is the same as secondary intention, but we let it be open first, let the body heal it, but when the gaps are close to each other already, then we suture it. The main difference in these three clinical approaches to wound healing is the scar or cosmetic result. The best cosmetic results is from suturing or the primary intention. The other two, the scar is less acceptable than the scar from suturing. So this is an example of primary, secondary, and tertiary intention. So in primary intention, you have a clean wound, so we can already suture that directly. In the secondary intention, there is an inflammatory process still, and the gaps are really wide, so we let the body heal by itself, and the scar would look like this one. This is still better than this one. And tertiary intention involves letting the body heal by itself until a time wherein the gaps are acceptably narrower, and then we do a suturing thereafter. So these are the examples of the primary intention. Okay, a better scar result. Secondary intention, it will still heal, but the scar is not so good. And the tertiary, we let it heal first, and until the gap will be closer to each other, then we close it via suturing. In my opinion, I think the best in the face is still a primary intention, because the face is very conspicuous. It can be seen by everybody. So our goal is to producing the best scar from any wounds that we will encounter. So it's still suturing in the face. So what are the goals of suturing wounds? First is hemostasis, that the wound should be infection-free, and there is optimal cosmetic results. So usually when you encounter wounds, it is usually bleeding, and suturing the wound will actually stop the bleeding, and the body will contain it. And the second one is, of course, the skin is a barrier for infection. So if you have the wound be open, infection is likely than if the skin is closed. Okay, so suturing will less likely to produce infection because you are actually restoring the natural skin barrier. And last is, of course, cosmetic results as discussed earlier. So part 2, preparing the wound, things that we have to do before suturing. We should eliminate factors that delay wound healing. And as much as possible, we should modify the conditions of the patient so that our wounds will heal in a timely and appropriate manner. So when you are the one who is suturing the wound, you can actually modify some factors before suturing, like cleaning the wound to prevent infection, removing necrotic tissues, and removing foreign bodies. So simple ways wherein you can prepare the wound so that it will heal in a timely manner. We should also control bleeding before suturing. Okay, like wounds again presents with bleeding. So the goals of controlling bleeding is to prevent hematoma formation. Okay, hematoma formation is a collection of blood behind a sutured wound, and this hematoma formation will not close the gap. Before, we already discussed that the gap should be closed. Okay, hematoma formation will prevent that closure, so we really have to control bleeding before we close the wound. Also, when we control the bleeding, we're able to examine deeper structures within the wound, and therefore we can either refer this to another doctor if there is a worrisome finding beneath the wound. Like for example, if we encounter a exposure of a nerve or a bone or a gland wherein we cannot do it if there is really bleeders in the field. So we have to control the bleeding in order to examine thoroughly the wound. Okay, so it will tell you if you need to refer it to another doctor. How do we control the bleeding? First is the most simple technique. It is by manual pressure. Okay, you just put pressure on the wound, and it will take 5 minutes to stop the wound. An hour, it doesn't matter. As long as you put pressure, you will control the bleeding. We use this technique even in the operating room. Okay, if there is a problematic bleeding, we just have to put pressure in it, and almost always it will control the bleeding. The second way of controlling the bleeding is using instruments like a hemostat. Hemostat is a forceps wherein you just clip or you just clip the area where there is bleeding. It doesn't matter if you cannot pinpoint or zero in where the bleeding comes from. Just pinch the area, and the area will have a tamponade effect, and the blood vessel will stop bleeding. Ligation, on the other hand, is isolating the blood vessel, and if you see the blood vessels, you clump it and you tie it up. So that's one technique wherein you really have to find the specific blood vessels that is bleeding and you tie it. And the last is suturing. Okay, so of course when you already finish this lecture, you will have an idea of how to suture, and controlling bleeding can be done by suturing. So earlier I told you that if you clamp the general area where the bleeding is, you can also actually suture it and tie it, and it will also tamponade the area, and the bleeding will also stop. Okay, so this is an example of hemostats. Okay, we clamp it. And the last is cauterization. So cauterization involves introducing heat to the area, and this heat will actually coagulate the said area, and hopefully it will coagulate the blood vessel that is producing the bleeding. So cautery or electrocautery can be found in most hospitals or even in some clinics, so you can actually use them to stop the bleeding. We should also remove the Vitalize and necrotic tissues. Like in this example, we have a wound here, and you see the edges of one, and you see here we already have a black edge, and this represents necrotic tissues or dead tissues already. Okay, we have to remove necrotic tissues because it will prevent infection. When the dead tissues become infected, it will delay wound healing. A dead tissue also will trigger a prolonged inflammatory phase, and thus it will also delay our wound closure. And dead tissue won't heal anyway. So for example, in this picture, if you try to suture a dead tissue to a living tissue, this will also die anyway, right? So you have to remove it, and you try to suture a healthy tissue to another healthy tissue so that you will have a good wound healing. So how do you remove the vitalized tissues? You have to cut it or debride it using blade or scissors. Usually these tissues are dead, no? And they are not painful, okay, when you cut them, because even the nerves are also dead in this area. Okay, but if in doubt, just apply some anesthesia before cutting the tissues, okay, so that you'll be able to cut it with the comfort of the patient in mind. You also have to remove all foreign bodies in the wound. So example, in this wound we have shards of glass. Okay, the goals of removing all foreign bodies in the wound is that foreign bodies will harbor infection, and removing it will prevent infection. Foreign bodies will also elicit inflammation, and it will prolong the inflammatory phase. And of course, the foreign body represents a gap. Okay, a gap again. So there is an actual physical object that is blocking the closure of the gap. So you have to remove it. Okay. So how do you remove it? So first, and the most practical way, is to irrigate the wound under running water, just like this one. Just make sure that the water that you are irrigating is clean. You may use bottled water or any water that is clean, or probably a saline solution. As long as you irrigate it, there is some kind of pressure. You don't just wet it. There must be some pressure that runs through the wound so that the foreign bodies will be carried away. In the hospital, we usually flush it using a syringe or a septic syringe. We flush the wound so that the foreign bodies will be carried away. You can also do manual extraction if you can see it, probably like wood or splinters or glass. Some glass shards are really difficult to locate because they are transparent. Others, like dirt or vegetable elements, you have to remove them manually. In cases wherein you cannot locate the foreign body, like example, it is embedded in the wound, you can actually do an X-ray, ultrasound, or CT scan to locate it, then try to remove it as possible. So what is the timing of suturing? You may ask, do you have to suture it right away? Or for example, if you are responding to a wound at home, do you really have to go to the hospital right away? Or in cases wherein you're attending to one patient, a very critical patient, and there's this patient who needs suturing, do you really need to suture right away? So here comes the principle of timing of suturing. First, you should be able to categorize the wound if it is a non-bite wound or a bite wound. Non-bite wounds are those wounds that are inflicted by like inanimate object like wood, glass, knife, etc. And bite wounds are those caused by animal bites, probably human bites. Okay, the difference between the two, bite wounds usually have saliva and some bacteria in it. Now, in non-bite wounds, if it's in the face, you can still delay the suturing up to 24 hours and there's no significant infection that will happen. Primarily because the face is really well vascularized. The more blood vessels you have, the more it is resistant to infection. But in the rest of the body, you can plan to close it probably after 12 to 19 hours and there is still no significant infection that will happen. In bite wounds, on the other hand, the face, you can still suture it like a non-bite wound as long as you clean it thoroughly. Remember, the face is very vascularized, so if there's an infection or there's an infected saliva on it, the body can well combat it as long as you clean it thoroughly and you can close it. You won't run the risk of having an infected wound. But in the rest of the body, you can opt to have the secondary closure or delayed closure. You let the wound stay open for probably 1 to 2 days, okay, and let the body combat the infection, clean it, okay, every day clean it. Then after 2 or 3 days, you may opt to suture it so that you will have a good scar afterwards. So what are the basic instruments that you need? These instruments are usually seen in every hospital or even in the major clinics. So you need a needle holder to hold the needle. You need tissue forceps. So it can be either toothed or non-toothed. Toothed tissue forceps is designed for grabbing skin or grasping skin. Okay, and the non-toothed tissue forceps are designed to handle needle. Do not use a non-toothed on the skin because it will crush the skin, resulting to a poorer scar. And do not use a toothed forceps in handling the needle because it will slip or it will twist. Okay, so I would like to emphasize here the proper instrumentations in wound suturing. You also need a scalpel to hold the blade. We usually use blade 15 and blade 10 in the face because these are more precise. We also use scissors. So we use a dissecting scissor to dissect or to cut tissues directly. And you also need suture scissors to cut the sutures. So suture scissors usually are thicker and they are not as expensive as the dissecting scissors. So don't try to cut sutures using a dissecting scissors because dissecting scissors tend to be more precise, more thin, more delicate, and you may dent the cutting edge of your dissecting scissors if you're trying to cut the sutures. So again, proper instrumentations in the different kinds of scissors in suturing. You also need a mosquito forceps or a hemostat. It is used to clamp bleeders or even used for dissection. Okay, you tend to dissect areas, especially if you're trying to look for foreign bodies, you dissect. We'll talk now about the type of sutures that you need. What I recommend is you use the smallest suture that gives strength to approximate wounds and the smallest suture that can support healing and it won't spring back or dehisce. So a rough guide of the type of sutures that you need: the smaller the number of the suture, the bigger it is. So take this picture for example. We usually use O's. So we have 3O, 2O, O. So this is another table for the thickness of the suture. So usually it starts from O, then 2O, 3O, 4O, 5O, 6O, and 7O. In some hospitals, they call it 20, 30, 40, 50, etc. So the higher the number, the thinner it is. And the smaller the number, the bigger it is. So in the face, we usually use a 50 and a 60. And these are really thin sutures. This will avoid the tracking marks after suturing. So we use it very thin sutures. But in general, like in the trunk, in the hands, etc., use a 4O. But in areas wherein there is really thick skin, like the back, the scalp, the palms, and the soles, you may opt for a thicker suture like a 3O. What kind of suture material do you need? Actually, any. There's a study wherein there is no significant difference between the cosmetic outcome, wound infection, and wound dehiscence rate between any sutures. So just use any suture that is available. The more important thing is the thickness of your suture. But for me, my preferred choice for the skin is monofilament non-absorbable, example of which are nylon and Prolene. Let's talk about the type of suture needle. So usually suture needles come in different shapes, especially on the tips of their needle. And it also comes in different suture needles usually vary in the shape of their tips. The most common ones are the cutting and the taper needles. cutting, it is usually a triangular shape. Triangle, we have edges, sharp edges. Okay, like this one, we have a sharp edge, sharp edge. It can be a conventional cutting, or it can be a reverse cutting. So if you cut the needle on its tip, you can see if the triangle is downward or pointing upward. It is called the reverse cutting if it's pointing downward, and conventional cutting needle if it's pointing upward. We also have the taper needle, which is like a conical shape. Okay, and it doesn't have the straight edges. So the difference between the cutting and the taper needles is, in cutting, when you put it on skin, it actually cuts the skin through its edges, and this is very suitable for thicker surfaces like the outer skin, because the outer skin is very thick. So use a cutting needle on that. And the taper or the smooth needles are used to dilate. Okay, like if you put a needle here, it will dilate. It will cut the edges, it will just dilate. Suture needles can also vary in the configuration. It can be 1/4 circle, 3/8 circle, 1/2 circle, 5/8 circle, J-shape, compound curve, and a straight needle. So in skin suturing, use a cutting needle because of the reasons I told you earlier. The edges of the needle will cut through a thick skin, and you can use a straight cutting or conventional cutting or a reverse cutting. My advice is, if reverse cutting is available, use a reverse cutting. In subcutaneous suturing, because the subcutaneous area is fairly not thick, you use a round or tapered needles. Tapered needles is also called round or atraumatic needles because they tend to dilate rather than cut through. So this is an example of a suture needle. You can see here the brand name, the suture material, the thickness of the suture, if it's reverse cutting or tapered, and also the configuration, the needle. It is a 3/8 circle. You can also see here how long that needle is. It's around 1.9 centimeters long. Here we'll also see the length of the suture itself. So if you have to suture a longer wound, you may choose a longer suture length. And now we'll go to preparing your anesthesia. We usually use lidocaine, either 1 or 2% lidocaine. This is a picture of lidocaine. And we usually mix it with epinephrine. Epinephrine, when added to lidocaine, will have vasoconstrictive effects. Epinephrine, when injected into the wound, can stop the bleeding. It will slow absorption. Epinephrine constricts vessels. That's why it can stop the bleeding, and it also stops absorption. So there will be constriction of the draining vessels. And when you slow absorption of your lidocaine, it will lower the lidocaine blood levels. We know that lidocaine has an effect to other body parts, like typically the heart. So adding epinephrine will lower blood levels. Therefore, there will be less systemic toxicity, and more of the lidocaine therefore will remain in the nerve or in the area which you were trying to anesthetize. It is very safe even to the ears, fingers, and toes, as many studies have shown. Usually the most common dilution is 1:100,000, which means that you have to mix 0.1 ml of epinephrine to every 10 ml of lidocaine. This is fairly easy to remember, and you just tell your nurses or your assistants to prepare this manner. So if you have to prepare 20 ml, just put 0.2 ml of epinephrine. Okay, this is a calculation for the 1:100,000, but of course it's difficult to compute when you are already suturing. So this is a rough guide. So this one is a prepared lidocaine epinephrine solution, and it is said here that is 1:100,000. This is actually in the form of carpules, and this is the form that is used by dentists in their clinics. When we have our anesthesia ready, we have to inject it very, very slowly. Lidocaine, when injected, can be really painful for patients. So, as much as possible, you inject slowly, introduce a little lidocaine in the area, and when that lidocaine starts to have an effect, then you can slowly add more, and patients cannot feel pain anymore. Also, use very small needles. So, I usually use gauge 25, 27, and 30. Here, the larger the number, the smaller the needles. So this is a rough guide. 14 gauge is very thick, and 27 gauge needle is thin. So what I usually use is 25, 27, and 30. In Botox injections, we usually use 30. So Botox is relatively painless because it's really, really small. And the usual syringe that you can find in the pharmacies is gauge 23. It's still fairly big, so just prepare 25 and above. Okay, let's go now to suturing the wound. So before I start, let me remind you that there is no emergency in a pandemic. We are still in a pandemic right now. So before attending to any emergency, ensure your safety first, and remember to wear the appropriate PPE before doing any suturing. It will depend on the hospital that you're working in, but just follow their safety protocols. Gloving. You may use clean or sterile gloves. This is a clean glove. There is no evidence of significant infection in just using clean gloves. Yet, the suture and instruments should be sterile. So this is a picture of a sterile glove. You may use either. Thing to remember is we should make all the wounds linear. The final wound should be linear because it has the best scar after. If you are presented with a circular, irregularly shaped, or jagged edges or dead tissues, you have to trim it to become elliptical in shape. Like this one, this is a circular wound. Then you trim it to make it elliptical so that it will be converted to a linear wound. In the ideal world, you may wish that all the wounds you encounter are linear in nature, but in the real world, usually these wounds are much irregular, much worse looking. So just prepare to design an elliptical wound to convert them to a linear wound. So take this for example. We have a defect here of the skin, a circular at that. We have to design an ellipsis around. We may have to cut normal tissue so that it will be converted into a linear wound. This is much better than closing a wound which are circular, and if you try that, you will have dog ears. The elliptical wound design should be less than 30 degrees. More than that, you will have difficulty closing it. If the wound you encounter is super irregular, just like this one, just trim it and just suture it. Okay? You just have to opt for a scar revision later. So when we're talking about designing an elliptical wound, we should put into mind the axis of the linear scar that we are trying to achieve. Okay. If doing an elliptical wound, what axis of the skin should the linear scar be? Now, this I always ask my students, if you have a circular wound over your cheek, how would you design the elliptical wound? Should it be vertical? Should it be horizontal? Should it be diagonal? So it's important to know where to place that elliptical wound and thus that linear scar, that the scar will be better after your surgery. So we actually follow the relaxed skin tension lines, or the RSTL. Okay, in our body we have invisible lines, and these are what we call the relaxed skin tension lines. The linear wound should be placed parallel to these tension lines, and these tension lines correspond to the dynamic pull of skin on healing. So in the face, we have these invisible lines. Actually, it corresponds to the pull of muscles, no? Like, for example, the pull of the frontalis muscle. So you have lines here. The pull of the zygomaticus muscle as well. You have creases here. Okay, and also the orbicularis oris. Okay, it's a pull. And the folds that are produced by the pull of these muscles corresponds to the relaxed skin tension lines. It is also seen in the wrinkles of old people. Okay, that's wrinkles usually form along the relaxed skin tension lines. Okay, if you get a mirror and take a look at your face and you smile, you'll have lines. Those are actually relaxed skin tension lines. So again, going back to my question, if you have a wound in your cheek, okay, you should design the elliptical wound that is following the relaxed skin tension lines. Okay, like this one, this will produce a better scar than going against it or going perpendicular to the line. Okay, don't do this, do this, because it will produce the best wound healing and scar. So try it yourself. Okay, one technique to remember is you can pinch the skin. The axis wherein the pinching is easiest typically corresponds to the RSTL. For example, here it's softer than this one, so this must be the relaxed skin tension line. So also in the arms, no, try to pinch it. So if this pinching produces a softer pinch than this one, so try to pinch in order to know the RSTL. But a better suggestion is you keep a photo of this one, of this, put it in your phone, and try to review it before suturing a wound or designing an elliptical wound. That's why before suturing, I always recommend you draw or you design your elliptical wounds before actually cutting them. Just to review. So the next concept is undermining the skin. So ideally, there should be no tension on the wound when you suture them. So these are the skin edges of the wound. When you're suturing both edges, there must be no tension wherein the skin will tend to open it up again. So what you do is to separate the skin from the underlying tissues so that there will be no tension. You relax all the tensions underneath the skin so that the skin will stay in the middle and there's no movement because of tension. Because when there is tension, ultimately there will be a gap sooner or later, because this one will tend to pull this one and this one will bend the other way. You will have a poorer scar if you have tension. Okay, whereas it can gape after removing the sutures, so it's not really good. So you should undermine the skin and free it in a way that even if you still don't suture it, it will stay opposed to each other. Do not force tissues to be approximated. Do not strangulate it. And here comes the principle of undermining the skin from the subcutaneous tissue to relieve tension. Undermine the skin from all sides, including the wound edges. So this is how we undermine the skin. You lift the skin up and separate the subcutaneous or the muscle from the skin, either using scissors, dissecting scissors, or blade. This one, they use a blade. They just raise the skin flap up and separate it so that it will be able to be approximated without tension. So you should undermine all sides, including the wound ends. So this is inadequate. You should undermine all sides. Okay, you lift it up, then you separate the underlying tissues. Let's talk about instrument handling. So when we're handling scissors or needle holders, the ring finger and the thumb should engage the instrument. So it's the ring and the thumb, okay? And the pointer finger should be ideally in the hinge, okay? So it stabilizes everything, okay? Remember, ring finger and thumb. So it can be in using scissors or needle holders, okay? Always use the pointer finger to stabilize the instrument so that it won't shake, okay? It's more steady. Avoid wrist in the supine position. So always when you do surgeries, the wrist, if you can see here, it's always in the prone position, okay? Avoid doing like this one or twisting like this one. It's not ergonomic. So always in the prone position. If you cannot help it, like you really have that to have that arc, what you do is to release and reconfigure it, going back again, okay? So we maneuver the skin or the needle so that the wrist is always in the prone position. And use the appropriate instruments. As I told you earlier, do not use mosquito forceps for needles. Use a needle holder instead. Use toothed instrument for skin. Okay, the principle here is it's better to pierce the skin than to crush it. Okay, crushing the skin and the edge will produce a very bad scar. Again, do not use dissecting scissors to cut sutures because dissecting scissors usually are more expensive, are more fine, are more delicate. Use the appropriate suture scissors so that you won't be replacing your instruments often. And avoid using fingers to pick up skin, needles, or blade. Using your fingers, you run the risk of injuring them. Handling the needle, handle the needle only with a needle holder. Hold it at its rear end near the suture, typically in the posterior 1/3. Holding the needle at the anterior one will decrease the arc of your suturing, and putting it way behind the needle, it will tend to bend the needle. So the sweet spot is the posterior 1/3. And pick up the needle with thumb forceps on the other side, just like this one. You pick it up. Do not pick it up with your fingers. We go now to suture techniques. There are many techniques in suturing, but in this lecture, I will just talk about simple interruptive suturing because it is the most basic. If there's one technique you should master, it should be the simple interrupted suturing. It is suited to all types of wounds. As shown here, this is from the said journal. So in the face, you can use simple interrupted suturing. In the scalp, in the trunk, in the upper extremities, in the lower extremities, in any mucosal surface like lips, oral cavity, and genitalia, still simple interrupted suturing. And even in major surgeries, simple interrupted suturing is one of the most reliable technique. I'd like to call this as the white shirt, black dress type of suturing. Like white shirt, black dress. You could never go wrong and you could use it in any occasion. So simple interrupted technique is like this one. You use the 1 cm rule, wherein you suture around 1 cm from the wound edges, 1 cm. Okay. And sutures should be spaced 1 cm from each other, like that. And the needle should enter and exit the skin perpendicularly at 90 degrees. So this one, 90 degrees, and this one 90 degrees. So in order for you to have ergonomic suturing, like this should be the 90 degrees, okay, you hold the edge of the skin up so that you can enter it from the side, and it's still 90 degrees. So it's 90 degrees this way, but it's a little more difficult. So lift the skin up and suture it from the side. It's still 90 degrees. You should respect the arc. And the wound closure configurations can be of 3 types. We have the everted type. The everted, wherein the edges form a mound after suturing them. And we have the planar, wherein the wound edges doesn't have a mound, it is just a plane. And we have the opposite of everted, which is inverted. The wound edges everts down. So a lot of plastic surgeons advocate everted wounds, okay, like this one, because we believe that wound contraction after the wound heals, probably after weeks, the skin will contract. Ultimately, it will end up being planar after several weeks. Okay, from this one it goes this one. But in a study, cosmetic outcomes appear to be similar whether the wound edges are everted or not. Okay, so whether it is planar like this one or everted, there seems to be a similar cosmetic outcome. So you can use both. It is acceptable. However, I want to emphasize to avoid inverted wounds because it will result into a depressed scar like this one. Okay, this is an inverted wound, and I do not recommend this one. Knot tying. You just have to remember 2 knot tying techniques when you're suturing. The first is the surgeon's knot. Use a surgeon's knot on the first tie. Okay, the surgeon's knot is this one. It produces 4 twists. These 4 twists results from 2 clockwise loops before picking up the end of the suture. So there will be 2 loops. I will show that in a video. And the succeeding knots after the surgeon's knot is what we call the square knot. A square knot has 2 twists compared to the surgeon's knot, which has 4 twists. The square knot is produced by 1 clockwise loop instead of the 2 of the surgeon's knot. And the knot should be at the side and not on the wound itself. So this is the wound, it should be on the side. The knot's end should be cut around 2 centimeters so that it will be easier to remove it when the time comes. So always remember this picture. First is a surgeon's knot, 2 loops, it will produce 4 twists, and a square knot, 1 loop, but it will produce 2 twists. I will show that in a video. Part 4 is post-op care. Things to do after suturing. First is cleaning the sutured wound. Patients can actually take a bath after 12 hours because a clean wound is always desirable. Okay? Don't restrict them in taking a bath because a clean wound will always result to a better scar. Any cleaning solution is okay. This is already proven by several studies. So you can clean it with soap and water or even hydrogen peroxide. It's still okay. But I personally want to tell you to avoid iodine solutions because it is itchy. Since any cleaning solution is okay, try not to prescribe iodine solution because patients will have to buy them. Just tell them to clean it with soap and water. Types of dressing. So no dressing is superior to others. So even open dressing or no dressing is okay. This is a recommendation from the Cochrane Wounds Group. Cochrane is one of the world's leading evidence-based research groups, and they recommend even no dressing is okay. Now personally, I always take a look at this local factor, which is desiccation and dehydration. Okay, desiccation or dehydration will actually delay the wound. So personally, I use a Tegaderm on dry wounds. This one. A Tegaderm is a film dressing. It looks like a plastic and place it on the wound. The reason that I use Tegaderm is that the film will discourage evaporation of water from the wound. We want the wound to have much water content as it will need the water for proper wound closure. So if you put a film over it, water will not evaporate and there will be no desiccation or there will be no dehydration of the wound, and the wound will heal better. So this is how we apply Tegaderm. And another application of Tegaderm. This will discourage water evaporation. Sometimes I use cling wrap, the one we use for food, especially if the wounds are very long or there is no Tegaderm available. It has already been studied by a Japanese research team that cling wrap is safe to use. Both of them will trap water from evaporation, preventing it from desiccation. For wet wounds, on the other hand, especially those with pus or blood or exudates, I use gauze. We need to absorb the pus, the blood, excess fluids in the first 2 or 3 days. But when it becomes dry already, I convert it to Tegaderm or a cling wrap. Antibiotics. Again, we have to know if the wound is non-bite or bite wounds, primarily because bite wounds contain a lot of bacteria. So in simple non-bite wounds, you just have to apply mupirocin ointment. It is an antibacterial ointment 2 times a day, like this one, and use an ointment instead of a cream. Ointment is petroleum based. It means that it will trap water just like Tegaderm will, and water based, it evaporates, so there will be no protection against evaporation if you use cream. In other countries, they use petroleum jelly for simple non-bite wounds. You will just have to trap water and that's it. They do not believe in the routine use of systemic antibiotics, especially if it's just a simple laceration. Cleaning the wound, irrigating the wound, removing foreign bodies will suffice, especially in the face because the face is fairly resistant against infection and it will heal fairly quickly than the rest of the body. So personally, I don't give systemic antibiotics. In bite wounds, however, especially from cat, dog bites, or human bites, the rate of infection is high, especially on cats. No? Usually, the bacteria that is present is Pasteurella and Staphylococcus, and therefore you give antibiotics to combat this. like amoxiclav or clindamycin. Skin wounds on the face is considered a clean wound. A clean wound, compared to the other types of wound classification, is usually there is no entrance to the GI tract, GO tract, or the respiratory tract. So simple skin lacerations are usually classified as clean, unless it becomes infected already when presented to you. But majority of the lacerations are clean. This is important when we do our tetanus wound management. So clean minor wounds, usually we just give tetanus toxoid for those patients with fewer than 3 doses. Otherwise, we don't give anything. We give tetanus toxoid 0.5 cc intramuscular on the left deltoid, and we also give human tetanus immunoglobulin 250 international units intramuscularly in the right deltoid if patient presents with a contaminated or high-risk wounds. So the golden time of tetanus toxoid is 5 years in contaminated wound and 10 years in clean wounds. Otherwise, if it's clean and the patient has history of immunization within 10 years, it's okay not to give. As doctors, you also modify factors that can delay wound healing well after the surgery. So you must refer the patient to an infectious disease specialist if the patient has immunodeficiency syndromes. You should control diabetes. You should control anemia, because anemia will result to poor perfusion. You tell the patient to avoid smoking, and you provide nutrition support in order for the wound to heal well. Otherwise, if you don't address all of this, you will expect that your wound will heal longer. So suture removal, this is a table for the timing of suture removals. In the face, it's usually 3 to 5 days because the face usually heals fairly quickly. But if you go downwards to the chest, arms, trunk, legs, hands or feet, soles, the timing of removal is quite longer because the healing also takes quite longer than compared to the face. Okay, so in the scalp, it's 7 to 10, in the arms 7 to 10, trunk, legs, hands and feet, usually 10 to 14 days, and the palms and soles, which are the most distant from the face and has thicker skin, usually you remove it 2 weeks to 3 weeks. So my lecture now is finished. So if you have any questions, feel free to contact me, this email or text, or visit my FB page. Thank you.